Hi, welcome to MD Newsline. Thank you so much for joining us.
Thanks for having me.
Please introduce yourself to our audience.
Sure. My name is Natalie Bellini. I am an assistant professor of medicine at Case Western Reserve University and the program director for diabetes technology at University Hospitals in Cleveland, Ohio.
Perfect. Thank you. I really want to get into talking about type 1 diabetes screening specifically with you, and I'm excited to talk to you about technology as well. Type 1 diabetes is increasingly recognized as a condition that can be staged even before clinical onset. Can you talk us through kind of the current staging framework and its clinical implications?
Absolutely. So, back in 2015, the American Diabetes Association published an article on staging of type 1 diabetes. And so, we know that type 1 diabetes is an autoimmune disease. And when we look at that, we can actually look at antibodies to type 1 diabetes. There are 5 antibodies that we can draw. And now we can stage that disease. So, we can say someone has
Mm,
2 or more autoantibodies with no dysglycemia at all. That is called stage 1 type 1 diabetes. We can code that when we actually see those people.
mm,
We know that if they have 2 or more antibodies that are positive, they do have a 100% lifetime risk of developing type 1 diabetes. But we can see those people and identify those people before they even become dysglycemic. So that's called stage 1 type 1. Stage 2 type 1 diabetes is when someone develops dysglycemia, so that
mm,
beta cell function is starting to fall, and that person is actually can't. Typically, it is, we see it with post meal numbers first. We see that first phase insulin response where they eat a high carbohydrate meal and their glucoses start to rise. They come back down though. So we see it as their beta cell function is falling and they just can't make enough insulin to do those things. Fasting glucoses start to rise a little bit. And then stage 3 type 1 is what we know and love, what we treat today, which is those people need insulin and they don't make enough insulin to cover daily life. If we catch it early enough, we actually do have some residual insulin function left when we actually see those people. And those people actually have something called the honeymoon phase. And they end up, when we diagnose them, typically with about 10% beta cell function left. The challenge with type 1 diabetes is because it's an autoimmune disease, eventually they're making no insulin at all. And there's even a discussion of a stage 4 type 1, which is for people who have long-standing type 1 with no zero insulin production at all.
wow. Um, so when it comes to kind of adoption of these new screening guidelines, what are some of the challenges maybe that you see or things that you're looking forward to regarding those
So
new screening
so
guidelines?
we screen to for a couple of different reasons, right? We screen to reduce that risk of DKA. We
Mhm.
screen because there is a product that is used at stage 2 type 1 diabetes called teplizumab to delay that onset of stage 3 type 1. So right now, the American Diabetes Association, ISPAD guidelines, EASD say we should be screening first degree relatives of people with type 1. So if I have type 1, that's my brothers, my sisters, my parents, and my children,
Mm,
right? Those are our first degree relatives. And those people have an increased risk of developing type 1 diabetes. So those are the people that we screen at this point. Other countries, such as Italy, do population health screenings. They're screening children right now between the ages of 2 and 3, between the ages of 4 and 5, and then again at 9 to 11, looking for both type 1 diabetes actually and celiac disease, which tend to run hand in hand, as well as thyroid disease runs hand in hand. These are all autoimmune diseases. But Italy is actually screening for type 1 and celiac together.
mhm. What about kids, like the kids of people with type 1 diabetes? Does
So children of people with type 1 have, if I had type 1 diabetes, my children do have a higher risk of developing type 1 diabetes, which is why those are the people that we're screening, right? First degree relatives.
mm,
So screening does 2 things. Screening reduces that risk of diagnosis at very high glucoses, of diagnosis in DKA. It reduces the risk of that. So from about 65% down to about anywhere from 2 to 6% risk of DKA. DKA, diabetic ketoacidosis, can change the trajectory of the diagnosis for that person. So DKA in and of itself can changes IQ, right? Reduces IQ.
Mm.
But it also, people that are diagnosed in DKA have higher glucose fluctuations from the get-go. They have more fluctuations. Their glucoses are harder to manage from day one. Where someone we know is developing type 1, we watch them, we see them. Endocrinology, diabetology follows these people, and we can help them have a softer landing at diagnosis.
So, what are the main barriers to widespread adoption of screening for type 1 diabetes? And what are some of the things that you've seen, even in practice, of how those barriers can be overcome?
So one of the biggest barriers is that people don't know what to do when someone is positive. They don't understand that screening is important. They don't understand that it reduces the risk of DKA, or that the guidelines have now changed to say you need to be screening first degree relatives. That's an American Diabetes Association guideline, right? So, and they when we think about who would be screening, that would be primary care and pediatricians.
Mm.
So if there isn't an intro into endocrinology, people don't want to screen because they don't know what to do. So when I talk about it, when we're teaching, the residents or the fellows about this, if you think about it, when someone screens for breast cancer, they know what they're doing. They order the breast cancer, and it's going to go to the surgeon. It's going to go to oncology. It's going to move out past that person. If they screen order a colonoscopy for colon cancer, they know it's going to go to the colon surgeon. It's going to go here. It's going to go there. When you screen for type 1, we need a pathway to get to endocrinology, so that if the antibodies are positive, there needs to be a place to go. And so in our practice, what we've done is we've held slots for them, so that when primary care screens somebody, when a pediatrician screens an older sibling into adult care, we have a spot for them. If you call my office today, it's May of 2025. You're not going to get in till December. So if you have an antibody positive person sitting around until December, they could actually convert to full blown stage 3 type 1 by then. So the goal is to get them in sooner, to help intercept that and get that person's education started. Type 1 diabetes can be overwhelming. This person's going to need insulin when they eat. They're going to need insulin overnight in the basal. They're going to need to learn how to count carbohydrates and understand a lot of different things. So if I can make that happen earlier in the process, that will help that person succeed and avoid that risk of DKA as well.
Interesting. Um, and how does early identification of maybe pre-symptomatic type 1 diabetes kind of change patient management or outcomes? Are there any interventions that you're excited about? How does that kind of change their course of disease development?
So right now there is one medication that is FDA approved to delay the onset from stage 2, which is antibody positive but with dysglycemia, to stage 3, called teplizumab. Brand name is Tzield, and that is the one medication right now that is used to delay the onset from stage 2 to stage 3. There are other medications in development, though, looking at stage 1 to stage 2, that delay from stage 2 to stage 3, as well as right after diagnosis. There are trials now that are going on that they're looking at early intervention with someone less than 6 weeks into diagnosis, because remember, there's some pancreatic function left. Those beta cells aren't all killed off yet, so they can still make a little bit of insulin. Can we stop that disease process at that time, that antibody activity against those beta cells, so that we can then stop it earlier and keep that honeymoon running? That basic background 10% beta cell function really does protect that person. It could protect them for years and years.
Mm. So, yeah, that's interesting. My mind always goes to how maybe even gene editing over time can impact. Have you thought at all about what you hope to see in the future? Is there any emerging research that has caught your eye as far as
As gene editing kind of, yes.
yeah,
So
or even any sort of emerging research? Because just the idea of someone getting to a stage where they don't produce any, insulin at all, it's like the point of no return.
right,
Uh, and then
right.
there's no going back. And I'm like, I feel like technology can get us there. I'm sure someone's working on it, but what do you think?
So there's a couple of things. We do know that the HLA gene is part of the challenge, right? But we also know that it's more than one place on those genes. So it's a little bit more difficult than we think. They also know that an autoimmune response, our immune system keeps us alive every day, from touching dirty doorknobs to, like just someone coughing, and you don't get sick every time that you would think you might, being exposed to different things. So this autoimmune process that we're fighting against is pretty strong. But there are some things that are being worked on with gene editing, with identifying people who have genetic susceptibility. In the United States, that's all done in studies. Like, I can't order genetic susceptibility for type 1 diabetes in a regular lab, like at LabCorp or Quest at this point. It doesn't exist, right? So it's still research based. But I do believe that in the future, we're going to be able to find those answers and help identify those people earlier, and then come up with treatments that make sense, that those people will never be insulin dependent.
Mhm. I wonder how that's going to be covered by insurance.
Yes, exactly.
That's
Oh,
always,
we know that that's always the challenge,
yeah.
right? I mean, that is the underlying question always, is how is insurance going to cover some of this?
Mhm. So you oversee a program following 65,000 people with diabetes. That's a ton of people. Tell me a little bit about that program, first of all.
So the University Hospitals in Cleveland, Ohio, actually follows more closer to 100,000 people
Wow.
with diabetes, and it is in Cleveland, Ohio. We have a very high rate of diabetes in the inner city, but we're also out towards the suburbs as well. So it's a very mixed population. About a third of the people that I see have Medicaid, about a third have Medicare, and the rest have private pay. So it's about a 60-40 split between Medicare, Medicaid, and then private pay. So we have a wonderful mix of people with all different needs. And when we look at using diabetes technology in all different patient populations, we use it inpatient, we use it at discharge. One of the things I'm most excited about in 2025 when we look at diabetes technology is that we are presenting data at the American Diabetes Association about our discharge plan. And we are using continuous glucose sensors at discharge. We have pharmacists working to follow those patients on an outpatient basis as they bridge towards their primary care doctors, looking at their continuous glucose sensors and helping titrate their medications to get those people to blood glucose or to glucose goal, and reducing that risk of readmission down from like 18% in the first 30 days down to less than 6% readmission rates. So when we look at diabetes technology, it's not just for oh, I can do everything and I'm going to count every gram of carbohydrate and I'm going to do this and I'm going to do that. Just putting a sensor on people as they walk out of the hospital to reduce that readmission rate, and just having someone help hold their hand, as well as hold the hand of the primary care provider who may not have the time to look at the data. Well, the pharmacist is doing it and saying, hey, look, let's do this. Let's change this medication. Let's help this person to reduce that risk of readmission. Because like you had said before about insurance doesn't cover readmission, right? So if someone's getting readmitted, that readmission isn't covered. And we're using continuous glucose sensors to keep those glucoses in range to reduce that risk.
Mm. Going from maybe not knowing you have diabetes to trying to get good at monitoring yourself and understanding how things like food impact it feels like adding technology to that is throwing another wrench in the situation. I'm wondering what some of the challenges in integrating new diabetes technologies like CGMs, automated insulin delivery, or maybe like digital health platforms. How do those not only factor into your work, but how are patients responding to having to integrate some of this stuff into their day-to-day lives?
So it's interesting you say that, because if you ask someone to stop and take out a meter and stick their finger and bleed onto a meter and then look at the number, a lot of them would rather wear technology because they can just put it on. A lot of people, the iPhone apps work with almost all the iPhones, right? Android is a little bit different simply because some of the Android phones won't hold those medical apps, right? They just won't do it. But people actually don't mind wearing CGM specifically. A lot of them actually like it, and they come back and they say things like, "Oh, on Friday nights when I go and eat pizza, my glucose goes high." Okay, so what can we do? I don't want you to not to go eat your pizza with your friends, but maybe 3 pieces is too many. Maybe 2 is enough, or maybe you go bowling when you do it so that you're moving a little bit more, and helping someone learn what does change glucose, right? I went out with my grandchildren, went to the playground, and I was flat all day. Those kinds of things. I was sick, and my numbers went up, right? So learning, we can tell someone that. We can write it on 11 different pieces of paper and give them handouts. But when they see it in real time and people look at them, even people that you would think, I don't know if this is going to be something that they like or not. A lot of times, if I say to them, look, this one's free, we give it to you, wear it for 2 weeks and let me know what you think. And so then I get a lot of feedback of, oh no, I really did like this. Or I don't want to wear it all the time, but I'm willing to do it again. Or I learned a lot, So we do get we it's not all positive, but it's certainly not all negative either, especially if the other option is to stop and stick your finger. So because they don't see the blood, they don't do any of that side of it. And the sensors last anywhere from 10 to 15 days now. So it's really, you just put it on and there you go. And that makes a huge difference to people with diabetes or even people with prediabetes.
Mhm. Have you seen any trends in maybe the ability to adopt these in any populations, or any trends in insurance coverage, or equity, or any of those types of things when it comes to serving different populations?
Excellent question. So the one of the very nice things is some of the pumps are now available or about to be available through pharmacy benefits. And so that's really nice because you can go pick it up at your regular pharmacy, and that really makes a difference. Two of the available pumps right now on the market have also been FDA approved for type 2 diabetes. So that opens up a whole new era. Now, we were using them off label for type 2 diabetes, but now not only are they FDA approved, but that means we can go in and teach the providers how to use them without being off label. So that pharmacy benefit helps a lot. The ability to use it for people with type 2, a lot of people with type 2, even if they do nothing wrong, need insulin. Diabetes is a progressive disease, and we have all these amazing new drugs. We have once weekly GLP-1s, we have SGLT2s. They reduce the risk of heart attack and stroke. They do all these things. But a lot of times, if you live long enough, you do need some insulin. So we should be able to use an insulin pump with these people if they want them. It doesn't have to be complex. You can do it where you can put in a small meal, a medium meal. It doesn't have to be higher level math, and the outcomes, people love them. So my challenge for people who are thinking about, gee, should I start using insulin pumps in my practice, is that it's easier than you think it is, and you can actually see when people are making decisions. So I can look at a pump download and say, oh, on Friday nights, what do you do? And they'll say, oh, I go out with my friends, I do whatever. Okay, you need a little bit more insulin for that. I hope you're having a wonderful time. It's not to judge someone and tell them they're doing it poorly. It's to help them keep their glucoses in range no matter what they want to do. Whether it's I mow the lawn on Saturdays and every time I do that I get low, or I walk with my friends to the bus, or I go here, or I get on whatever. All of those things, exercise tends to make glucose drop, food tends to make it go up, and we can kind of peel back that onion and really look and have a more meaningful conversation than, did you take your insulin for dinner on Thursday? They have no idea what they did on Thursday. They have no idea what they ate on Thursday. So it really does help you can have a more robust conversation with the person that's sitting with you to try and help keep that glucose in range more often, and ultimately reduce the risk of heart attacks, strokes, micro and macrovascular complications of diabetes. I mean, that's why we do what we do. So the technology really is an aid to make that easier for the person with diabetes.
Mhm. Do you find that you're having to kind of connect the dots for patients more often than not, when you kind of look at their data and say, okay, well, what were you doing in this time, and kind of connect that to what they're seeing? Um, are most patients getting to a point where they themselves are kind of prompting and able to tweak their own behavior or lifestyle in order to keep their numbers in a more favorable place? Or do you feel like you have to continually kind of do that touch point? Do the training wheels ever come off with patients?
Great question. So for a lot of people, the training wheels do come off, right? For a lot of people with type 2 diabetes, we can keep it very simple, and their numbers tend to reflect that. Like, we just can get their time and ranges very high very easily, where we can say, breakfast is, put in 25 grams of carbohydrate every breakfast. If you eat out, go to 50. For lunch, put in 50. If you eat out, go to 70, right? And keep that very simple behavior. because their lives don't change that much, right? So you can, especially as someone ages, right? It's like, did I have a sandwich with, roast beef in it or turkey in it? It doesn't change the number of what's going to happen with the diabetes, right? So we can keep it very simple. Um, the thing about diabetes that's the challenge is it's a progressive disease, so things change, but also, you get a sore shoulder
Mhm.
and you need a shot of steroids, or you've got, arthritis and you need steroids, that's going to make your glucose go up. You ended up needing surgery for something that was irrelevant to diabetes altogether, and you're moving less. You had a knee replacement, for example, right? So you're supposed to move more. You don't for a while. That causes less activity, makes glucoses rise. Illness makes glucose rise. Emotional stress can make glucose rise. So there's so many things that can cause challenges. The automated insulin delivery systems, a lot of them can address a lot of that, and you don't have to change it in the background. But there are some, like the specifically steroid injections, those are really hard, and you do have to continue to tweak it, right? Diabetes is not a set it and forget it disease, though, for most people. And they do learn as they go, right? After church on Sunday, I can't have 2 donuts. I can have a donut if I walk. I can do this if I do this. I can. And those things, because they're wearing a sensor, a continuous glucose sensor, people do learn over time. And a lot of times people come in and I say, we're not making changes at all. Focus on trying to get your insulin in before you start to eat. You're good for the next 3 to 6 months, and then there's people in between where they just need more hand holding because life is hard, right? So the harder life is beyond diabetes, I think the more hands-on and hand holding these people need,
Mhm.
and they deserve.
When it comes to nutrition specifically, what's the most challenging thing for patients to learn typically? Because the idea of counting carbs to me just sounds so complicated. Like, how are you kind of teaching patients to kind of become experts a little bit on how meals impact their bodies?
So we start with really basic education, right? So, non-starchy vegetables don't really make glucose go up much, right? Protein doesn't make glucose go up much. Now, protein like fried chicken would, because it's breaded and fried, not because it's chicken, right? So, and then what are carbohydrates and how do you count for them? For a lot of people who are on, it can be as easy as, for every serving of carbohydrate, for every piece of bread, for every small apple, take 1 unit,
Mm-hmm.
right? For people who have more insulin resistance, it might be, for every piece of bread, take 2 units, or, right? So we would then change the numbers based on that. Um, so it does not have to be that you have to be able to read a label even. It we can work with someone and keep it as simple as they need it to be. There is a pump that you actually don't put grams of carbohydrate in at all, called the islet, and you say usual, less than usual, more than usual, and you just tell it, is my meal the normal size meal? Is it bigger than the meal or less than the meal? And it does it for you. So there are pumps that are designed for people that almost to reduce that diabetes burden. There are automated insulin delivery pumps that can be very specialized, that someone who is, might be, let's say, trying to get pregnant, and I need that fasting glucose below 95. I need that 1 hour below 140, those kinds of very tight margins where I need a pump that, I tell people I can make this one dance more to get you to goal to have a healthy pregnancy. We will pick the AID system based on what that person needs at the time. And those needs will change over time.
Interesting. Let's talk a little bit about GLP-1s.
Yes.
Us,
This is it, right? This is the
yeah,
hot
this is the
topic,
hot
right? Yep,
topic,
this is.
the
Yes.
the popular, the homecoming queen, it seems, of
Yes.
the diabetes world and so many other worlds. So you've done some research on GLP-1 agonists in type 1 diabetes and technology in diabetes care. What emerging therapies are you most excited about, or even emerging technologies?
So if we start with GLP-1s, I believe every person with type 1 should get to have a chance to use a GLP-1 too. And they're not FDA approved for people with type 1 diabetes. And when they first came out, we were using, we started using them pretty early. They have now demonstrated reductions in heart attacks and strokes. And, depending on the molecule, they are being used to treat sleep apnea, to treat reduction, to slow down the reduction of kidney disease. I mean, every day we feel like there's a new FDA approval, a new indication for something, right? People with type 1 diabetes, 60% of them have overweight or obese as part of their diagnosis on top of their type 1. So I just don't understand why we shouldn't be using them, right? So the challenge is most insurances don't cover them. I will tell you, we're very excited that they have announced that they are doing a trial for tirzepatide specifically for type 1 diabetes. And it's going to take a while, though. That's going to be the challenge. Trials don't happen overnight. Trials are very expensive. And when we look at big trials for people with type 1 diabetes, if you were a company and you were going to look at, I want to make a drug that will help keep our lights on, that will help our shareholders, that will help the people that we serve as well. There are, somewhere around 2 million people with type 1 diabetes and 36 million with type 2 diabetes. So if you were a company and you had to look at both groups, which one would you find a drug for, right? You would find a drug for the people with type 2 diabetes. So we know that there are off-label uses of GLP-1s all the time, and the outcomes are amazing. There are papers. Viral Shah just had a paper on use of tirzepatide with type 1. We've used it early on in early diagnosis of type 1, the GLP-1 class, and we love the outcomes. What we want is the insurance to cover it. And we had talked about insurance earlier in this conversation, and insurance doesn't cover it for people or tends to push back on for people with type 1.
Mm. Yeah. Um, what are other insights or kind of thoughts that you have around that research that you did, and its kind of way that you hope to see it maybe impact clinical work in the future?
So the early use, so we did, our first study was started the week that liraglutide came out. Liraglutide is actually a once daily GLP-1. It has been replaced by the once weeklies, but the minute it came out, we thought, okay, let's see what this does. And it changed the way I've practiced ever since, because lots of my patients get offered a GLP-1 early on because of that, because we now know that liraglutide, semaglutide reduces the risk of heart attacks and strokes. It reduces those major adverse cardiac events. So how do I not give that to the people that I see that happen to have type 1 diabetes versus type 2 diabetes? It also reduces their total insulin dose in the day. It helps with weight control. It helps with all the things that we're trying to do for people with type 1. And it really is a wonderful adjunct.
Interesting. Um, so when it comes to things like diabetes management, um, there's a lot of interdisciplinary work that is needed. Obviously, you've got to work closely with physicians, pharmacists, and a ton of other professionals. Even honestly, podiatrists. We've got a lot of
Absolutely. Retinal specialists,
exactly.
cardiovascular, that's it, right? We do the vascular surgeons, the heart surgeons, all of the people that help to manage all of those dentists.
Mhm.
We don't think about dental care and diabetes, but people with poor dentition have a higher risk of heart attacks and strokes. Well, guess what diabetes does? It increases your risk of heart attack and stroke. So convincing someone and getting the communication to the dentist of, look, this is my concern, all of that plays a role in it, right? And tracking all of that. People are supposed to get a retinal exam every year. People are supposed to, right? They have a little bit of neuropathy. I need to send them, to a neurologist, treat that neuropathy, to encourage exercise. There's a lot of communication.
Mhm. What is the key, do you think, to better interdisciplinary communication and harmony?
Wow, this is like the question of the day. So I think that having an integrated electronic health record makes a huge difference, right? If I say to someone, have you been to the ER recently? I can see if they've been to the ER because it's all integrated together under our one network, right? I can see if they've been to the eye doctor. And if I don't see it, I can say, now, where did you go? Right? Oh, I went to this place, and I can request the records, get them uploaded. But then it's, in the olden days when we used paper charts, you're like paging through and you don't know and you can't. But I can say, oh, you went to the ER. It sounds like you tripped. What happened? Tell me what. Oh, you had a low glucose. And so that it really does. I saw you went to the eye doctor. So they gave you an injection in your left eye. How is the vision now? What's happening? The goal of diabetes management, the goal of the glucose keeping that glucose in that tight range is to reduce the risks of that eye disease,
Mm,
right? So you're kind of always bringing it back to this is why we do what we do here. We're trying to protect your organs from the ravages of diabetes.
mm.
So that idea, because it's all relevant, because it's all relatable, and because you can see that those different facets, you really can have a more open conversation about what's happening.
Amazing. Well, this has been a great conversation. Thank you so much for joining us. Do you have any closing thoughts for us? Any message for your fellow practitioners?
I think ACE is a wonderful meeting to come to. It's been an amazing, and I love it because it's part of diabetes, it's part of endocrine, because so many people, I specialize in diabetes, but so many people with diabetes have other endocrine disorders. So to be able to come here to talk about hyperthyroidism and, treatment of the different other endocrine disorders that happen to play a role with diabetes has been an incredible opportunity. I look forward to the American Diabetes Association coming later this year, the Diabetes Technology meeting coming later this year, and I think getting together and learning as a group of professionals makes a huge difference. I feel so invigorated to go back to see people again on Monday.